Okay, well, most people are on now, so I think we'll start the talk today. Welcome everyone to Paediatric Lectures. I'm going to talk today about neonatal infections, and these are obviously very common problems that we deal with every day. I'd like, if people have questions or want to make comments or anything, please feel free to ask at any time or wait until the end. It's up to you. But I'm going to be talking today about neonatal infections, and I hope this is all the basics that you need to know for your exams. So by the end of this, I want you to be experts in how to detect infections in newborn babies. And there's many different types of infections. I think we probably have reduced it to neonatal sepsis. We talk about neonatal sepsis, but there are actually numerous different types of infections. And I want you to be experts in all the different types of infections that occur in newborn babies and in neonates. We'll talk today about the types and the causes of newborn infections. And in a way, you can break these up into those that are very focal and those that are systemic. And you can have systemic, I'll just let a couple more people in. You can have focal infections like cord sepsis or conjunctivitis or skin sepsis, and then you can have generalized infections, and those generalized infections can be either bacterial infections, what we often think of as neonatal sepsis, or they can be systemic viral infections. And the viral infections can either be acquired in utero, like the torches infections, what we often call torches infections. I'll explain what that means for those who don't know a bit later. Or viral infections can be acquired postnatally, because it's actually very common for newborn babies to present in the first few weeks of life, during outbreaks of respiratory syncytial virus with just a viral bronchiolitis. So even that can be a cause of infection. So we're talking about a lot of different types of infections today. And what I'd like you to do is have a bit more detailed understanding than just calling it neonatal sepsis and treating it with antibiotics. All right. So I first got interested in neonatal infections well over 20 years ago. But these days, we know that newborn infections make up more than half of all newborn admissions to hospitals. So last year, 58%, or 2019, I should say, 58% of newborn admissions were due to infections. And the case fatality rate for those was about 6%. That's when you combine all the neonatal infections together: neonatal sepsis, bacteremia, pneumonia, cord sepsis, meningitis, etc., etc. So newborn infections are a really big problem, and we need to be experts in distinguishing between the different types of infections. As I said, I got really interested in this about 25 years ago, when even in those days, there were newborn bacterial infections were common, and bacterial and multi-resistant infections were starting to emerge. And these infections caused disproportionate numbers of deaths in newborn babies, and most often they were because of multi-resistant gram-negative infections. And so we might think that they're just new things, multi-resistant gram-negative infections, but actually they've been around for a very long period of time, and sadly they cause a higher proportion of deaths. So in those days, even multi-resistant gram-negative sepsis occurred in 106 of 5,331 pediatric admissions, so only 2% of admissions, but it caused 25% of all deaths. So newborn infections are really important conditions, and we need to understand the antibiotic susceptibility of those infections. The problem of identifying neonatal infections is that most of the symptoms are very non-specific, aren't they? If a baby's not feeding well, or they're drowsy, or they're sleepy, or they're poorly conscious, then they may well have an infection, but they could have lots of other things too. And if you look at the whole list of, this is the list that the World Health Organization suggests as being the signs of newborn sepsis. Well, drowsy or not feeding well, fast breathing, grunting, that grunting type breathing, severe chest indrawing, a temperature above 38 degrees, a temperature below 35.5, so hypothermia or fever, cyanosis, apnea, severe jaundice, or severe abdominal distension. They're all signs of severe infection in babies, but they also can be signs of other conditions. And so when you think about a baby that's, for example, not feeding well, it may be a simple feeding problem, or it may be some congenital problem like a cleft lip, but it also might be some infection, such as a urinary tract infection or meningitis or bacteremia. And if you think about a baby that's drowsy or sleepy or unconscious, well, it might be a newborn infection, or it might be that the baby's just jaundiced, or they've had some birth asphyxia, etc. So as I said, the signs are very non-specific, and we have to be aware that many of these signs may be caused by other conditions, but they also might be due to some infections. When this has been looked at more recently in very large studies in South Asia, looking at newborn infections or mostly bacterial infections, it's been seen that these infections, meningitis, sepsis, pneumonia, and other just possible bacterial infections, overlap with lots of other conditions in the newborn period. So they overlap with birth asphyxia. Many babies with birth asphyxia have that because they've got an infection, or they might overlap in their clinical presentation with some sort of congenital infection, either congenital pneumonia or a torch infection, etc. They overlap with respiratory disorders or just other virus infections, diarrhea, urinary tract infections, even tetanus, skin infections, and even congenital heart disease. Babies with congenital heart disease have fast breathing, and often we mistake that for neonatal sepsis. So it is difficult to make a distinction between neonatal infections and other conditions, and I think it's important that we have ways to do that. When you think about newborn infections, I want to think about two different types of things. One is the type of infection, like where it is, and the other one is what is it caused by. And so the types of newborn infections can be pneumonia or bronchiolitis, of course. As I said, bronchiolitis can be postnatally acquired, or pneumonia can be postnatally acquired, or it can be acquired in utero, a sort of vertical transmission of bacterial pathogens often from prolonged ruptured membranes. The second is, so pneumonia or bronchiolitis, umbilical infections, so cord infections, they're very common. Skin, soft tissue, bone and joint infections, urinary tract infections, eye infections, diarrhea, bacteremia, so a systemic infection where there's bacteria in the bloodstream, or viremia, where there's the virus in the bloodstream. And remember, the viremia can either be because of an intrauterine infection, or it can be because of, I'll just let some people in now. A viremia can either be postnatally acquired or intrauterine acquired. And then congenital virus infections like the torches infections. The types of infections differ depending on the location of the infection and also the age of the child. But broadly speaking, we need to know about gram-positive infections, typically in the newborn period, Staph aureus and group B streptococcus are the common bacteria causing bacterial infections, gram-positive infections in the newborn period. And then gram-negative infections, which tend to occur a bit earlier. So E. coli, Klebsiella, Enterobacter, and Pseudomonas. And it's these ones, particularly these 4 gram-negative infections, they're enteric gram-negative infections. They're called enteric because they normally live in your gut or in your bowel. So they're enteric gram-negative infections. These are the ones that are most likely to be associated with multi-resistant, multi-antibiotic resistance. And then there's virus infections, as I said, intrauterine virus infections, those torches infections, and then postnatally acquired infections like respiratory syncytial virus and enterovirus, which can either be acquired from the mother or postnatally. And then there's some congenital infections like congenital TB, which we see sometimes, and congenital malaria, which we also see sometimes, and they can cause a febrile illness in neonates and look just like neonatal sepsis. There's been some good studies looking at exactly the types of infections. I don't think it's important that we understand all of these data, but just to know that in the first 2 or 3 days of life, what's called early onset neonatal sepsis, then gram-negative bacteria are a bit more common. So E. coli, Pseudomonas, Aeromonas, Proteus, they're all gram-negative bacteria. They're probably the most common types of bacterial infections in the first 72 hours. And then after that, the gram-positive infections like Staph aureus and Streptococcus become a bit more common. It's not to say that these gram-positive infections can't also occur in the first few days of life. They can, but more commonly are gram-negative infections. I'll just let a few people in. Late onset neonatal sepsis is a bit more likely to be gram-positive in nature. So Streptococcus pyogenes, that's group A Streptococcus, or Staph aureus, or Streptococcus pneumonia, they're the most common ones. But also the gram-negatives, the ones in red, are also quite common. E. coli, Salmonella, Klebsiella, Enterobacter. Haemophilus influenzae is a gram-negative bacteria, and then the other enteric gram-negatives, Acinetobacter, Pseudomonas, and Enterococcus. That's a gram-positive infection, but principally, I'll just let someone else in. Principally, it's a mixture of gram-positive and gram-negative infections in the late onset neonatal sepsis. That's usually we call late onset neonatal sepsis after the first week of life or after the first 72 hours. But in the first 72 hours, certainly it's called early onset neonatal sepsis. This baby, can someone suggest what this baby may have? This is a newborn baby born in the village, and what do you think the baby might have? If you look, you can see what the striking feature is: marked abdominal distension. And you might think that the baby's got a bowel obstruction or something like that, but in fact, you see how red the abdominal wall is. It's erythematous here particularly, and this is abdominal wall cellulitis. Yeah, cellulitis. That's right. The baby has abdominal wall cellulitis, and it's striking that you can have that much degree of abdominal distension from just cellulitis of the anterior abdominal wall, and it probably suggests that there's a functional bowel obstruction as well related to the infection, which sometimes occurs, or there's some ascites inside the peritoneal cavity because of the generalized infection. So abdominal wall cellulitis, and mostly that's due to a staph infection, mostly staph. And so whenever there's an infection of the skin or the umbilicus or of the soft tissues, it's mostly, these are mostly staphylococcal infections. What you need to do is ask what's the full extent of the infection. If you see a cellulitis or a skin infection, then is it just the skin? Are there just a few skin pustules, or is there something deeper? Is there an abscess that's deeper, or are the other soft tissues or joints or bones affected? Whenever we see erythematous staph infection, that's what we should ask ourselves. Is it just a superficial infection, or is it a deeper infection involving the skin, the fascia, so that's called fasciitis, or the muscle, that's called pyomyositis, or the joints, that's called septic arthritis, or the bones, that's called osteomyelitis, or has there been intra-abdominal spread, for example, that's called peritonitis. So we need to ask, is it a superficial infection, or is it more deep? And is the baby systemically unwell? That is it, I'll just admit some more people in, is the baby systemically unwell? Is it just a focal infection, or is the baby systemically sick? So when we're describing a child who's got neonatal sepsis, we need to be describing the source of the infection, the most likely source, whether it's focal or whether it's generalized, whether it's superficial or whether it's deep, and what the most likely pathogens are causing it. So you can tell from this infection, if you've got cellulitis, then most likely this is a gram-positive infection, and most likely it's a staph infection. And that's when we need to cover for staph, right? Mostly when we are giving antibiotics to cover for staph, like skin infections, soft tissue infections, bone and joint infections, then flucloxacillin or cloxacillin, they're the same, that will be adequate. We need to make sure we give enough of each. So enough of flucloxacillin, 50 milligrams per kilogram, 6 hourly for babies over a week of age, and for in the first week of life, usually you give it 12 hourly. We always add, initially, in a baby who's very unwell, we'll always add gentamicin as well. And the reason to do that is because you don't know that there's not also a gram-negative infection, and also gentamicin can cover some staphs. It has some cover for Staph aureus as well. So flucloxacillin and gentamicin if you suspect a staph infection. But the most important thing is actually to ensure source control. So if you've got some deeper infection and you're just giving antibiotics, then it's unlikely the infection will clear unless you get source control, that is, drain any pus that might be present. This baby presented also with an infection. So this is, again, a newborn baby, but the rash looks quite different, doesn't it? You saw the rash in the previous child, which was red and erythematous, but the rash in this child is not red. There's gentian violet paint on the umbilicus, but the rash here, these are called purpuric spots. When you see purpura, then you really need to think of a gram-negative infection. If we saw this in an older child, we would think, we'd think of Neisseria meningitis, meningococcal disease. A meningococcal disease is a gram-negative infection, but if we see this in a newborn baby, we should think of other gram-negatives that it could be. It could be meningococcal disease, but this baby had Pseudomonas. This is disseminated Pseudomonas infection. And when you've got purpura, that's particularly likely to be related to a gram-negative infection. But again, it's difficult to tell. I've seen erythematous macules recently in a child who had disseminated Klebsiella infection. So the distinction between red spots and purple spots is not necessarily gram-positive and gram-negative, but there's a bit of a clue in the colour of the spots that this is a gram-negative infection. So purpuric spots are typically gram-negative infections such as meningococcal disease or Pseudomonas, and we treat those with ampicillin or amoxicillin and gentamicin. The gentamicin primarily to cover for the gram-negatives. You can use other agents like ceftriaxone or ceftazidime. They can be effective also against gram-negative infections, but it's usually not the first line treatment. But if you found, for example, that the child's got Pseudomonas, then ceftazidime might be a better choice of drug. If you're worried that there might be a resistant gram-negative, then there's a number of other things you can do, such as using ampicillin and amikacin, or even one of the fluoroquinolones, such as ciprofloxacin, is sometimes used. So in terms of second line treatment, then you need to think carefully about what bugs could be there, and that's usually based on what bacteria are present in your nursery or present in the community. But in the first instance, then ampicillin and gentamicin is very effective for gram-negative infections in the newborn period. This child's got, this is another newborn baby, also born in the village and presented at 2 days of age with what you can see there, severe respiratory distress. You can see the severe chest indrawing. And I think it's important that there's a lot of overlap between all the different types of causes of severe respiratory distress in babies. But I thought that some people in India had a very good classification for neonatal pneumonia, for identifying pneumonia. And this is a slight modification of their classification, but it looks at different criteria, such as maternal risk factors, so a maternal fever or foul-smelling liquor or prolonged ruptured membrane. So any one of these risk factors should make us think that the baby might have pneumonia. Then clinical features of sepsis, such as poor feeding or lethargy or hypothermia or abdominal distension, and then an X-ray picture suggestive of pneumonia, and then a positive sepsis screen. So in any baby that's got respiratory distress and fever or hypothermia, we should think about congenital pneumonia or neonatal pneumonia. And the causes of neonatal pneumonia are a bit different to the causes of pneumonia in older children. And they go back to those pathogens I talked to you about before, that is in the first few days of life, then gram negatives are more common. So Klebsiella, Enterobacter, E. coli, and a bit later, gram-positives are more common, like Group B Streptococcus, Staph aureus, and Strep pyogenes. They're the most common pathogens causing neonatal pneumonia. The treatment for neonatal pneumonia is a long treatment, standard treatment, isn't it? We give oxygen, we give antibiotics. So the first line treatment, again, ampicillin or amoxicillin will cover gram-positives mostly, and gentamicin will cover gram-negatives. If you suspect Staph aureus, such as the baby's got some skin pustules, or the baby's got cellulitis, or there's something else to suggest a staph infection, then flucloxacillin and gentamicin will be the best combination of antibiotics. As I said, the second line treatment is something like amikacin or ciprofloxacin if you suspect these enteric gram-negatives, the extended spectrum beta-lactamase producing enteric gram-negatives. So if you think the pneumonia might be hospital acquired, or the baby is very sick and is not improving on first line treatment, then using amikacin or ciprofloxacin, or even a combination of both. If you find a gram-negative, that can be a useful thing. It's important to know that ceftriaxone, often we think that's a really good antibiotic, but it's actually no better than ampicillin and gentamicin in these babies with pneumonia. In fact, it sometimes is not as good, and I would prefer ampicillin and gentamicin or amoxicillin and gentamicin if the infection is just pneumonia. It's different if you suspect meningitis, then you're better off using ceftriaxone or a third generation cephalosporin for sure. This baby's got also similar to what I talked about before. Can anyone see something in that's wrong with this baby?
Swollen right leg?
Yes, the right leg looks quite swollen. It's not just swollen, is it, Glenson? There's something else about it. It's swollen and it's what?
Inflamed.
Inflamed, that's right. It's swollen, it's erythematous. It looks, what does it look like to you? What do you think the diagnosis is?
Cellulitis?
Yes, it is cellulitis, isn't it? Because you've got an infection of the skin, an erythematous infection of the skin. But you remember, you've got to ask the question: is it just cellulitis, or is it something more? Could it be deeper? And so, is it just superficial, or is it deep? Well, what do you think, Gladson?
Oh, you reach the bone.
Yes, the fact that you can
osteomyelitis or compartment syndrome.
Yes, that's right. It's more likely that this is a deep infection because there's so much swelling there. And again, that it's a clue that it's not just a superficial infection. So we should always ask the question. I often see children that are treated for cellulitis for several days, and nobody's asked that question. Could it be deeper? Could it be in the bones or the joints? And if we don't ask that question, then we just end up giving antibiotics to a child who actually needs something surgically done or some other intervention. So if we see signs that the infection is deeper, that there might be an abscess there, then we need to do something else besides just give antibiotics sometimes. Okay, and this baby, again, a similar issue. What do you think's going on with this baby?
If you show the
Yes, there's a big effusion of the right knee, isn't there? A very big effusion. It's not, and when you look at it, it's not just swollen, is it? It's swollen and it is really shiny. It's the shiny nature of it. It tells you it's under a lot of pressure. And not only is the right knee swollen, but also the leg is swollen, isn't it? The swelling over the tibia and the fibula. And what do you think that suggests?
Septic arthritis.
Yes, this is septic arthritis and likely osteomyelitis, isn't it? It's likely that there's not only septic arthritis, but osteomyelitis. And it was possible to drain 70 mils of pus from this knee. And again, it was Staph aureus, isn't it? That's what you expect, that this is most likely a Staph aureus infection. It could, of course, be some other bacteria, but 80% of these will be Staph aureus these days. And so this is another infection that sometimes you see. So we've talked about osteomyelitis and cellulitis, aseptic arthritis, and this one is a breast abscess, which sometimes you see as well. And again, this wouldn't clear up if all you do is give antibiotics. You've really got to have that drained by the surgeons. It's very important that they stay away from the nipple, of course, but you can drain it away from the nipple, and that won't affect the baby in the longer run. But yes, a breast abscess from Staph aureus. This also, what can you see there?
There is swelling around the cord. It's red, inflamed. I think it's tonsillitis.
Yes, that's right, omphalitis indeed. And this baby, I can remember we treated this baby for 5 days with antibiotics and wondered why he wasn't getting any better. He was still febrile, and the reason was because there was a deep-seated abscess within the fascia. So once it was drained, the baby got better very quickly. So again, you should ask yourself when you see what looks like a cellulitis or a superficial infection, is it really superficial or is there something deeper? And I think if you look, you can see that there's swelling all the way down to the suprapubic region, and the umbilical cord looks very abnormal, doesn't it? That doesn't look like a normal umbilical cord. The baby had not just a cellulitis, but also a abdominal wall sepsis with an abscess. Now, what we see this type of infection quite often, don't we? In a baby who may be a bit unwell, or they might have a fever, and sometimes there's some pustules draining, a small amount of pus draining from them. And this is very common, not a cellulitis infection, but it is a form of skin infection, just skin pustules. And there's lots of different neonatal infections that can look like this, and making a distinction between those that are staph pustule infections, staph skin sepsis, and those that are other things can be quite difficult. But it depends on whether the child's sick or well, whether they've got a fever or not, and whether there's any pus draining from the lesions. That's the question you should ask. And the reason I say that is because there's a couple of other infections. Well, they're not infections, actually. They're more hormonal imbalances that often we think that this type of, if you saw a baby like this with these small papular lesions, erythematous papular lesions, you might say, oh, this is a staph infection, but these are common. This is called toxic erythema of the newborn, and we don't generally need to treat that with antibiotics. It'll just get better by itself. We often do treat it as if it's a staph infection, but it usually will just get better by itself. And the key is that it's a small, very, very small papule or pustule surrounded by erythema, and they're usually not infectious, not due to staph infection, but we often treat it as if it is. And this is even more less likely to be infections. These white spots on the forehead, on the nose, on the mid face of a baby, they're just again sometimes called milk spots, and they're just due to the accumulation of sweat in blocked pores, and they also have a sort of hormonal dimension to them, and they mostly resolve in the first 4 weeks of life. So this infection, toxic erythema of the newborn, also sometimes called erythema toxicum, that is not a staph infection, and miliaria is not a staph infection either. But this one, where you've got pus draining from pustules and the baby's unwell or got a fever, then that's a staph infection. So they sometimes can be quite hard to make a distinction between the two. What about this infection?
Occipital cellulitis.
What do you think this is due to?
Gonococcal.
Yes, it's gonococcal infection, isn't it? It's gonococcal eye infection. You can see, sometimes we see some sticky eyes, but this is much more than sticky eyes, isn't it? These eyes are, the baby's crying, but the eyes are very, very swollen. Their eyelids are swollen and they're erythematous. They're very red and inflamed, and you can see some thick pus draining from the eyes. This is gonococcal eye infection, gonococcal ophthalmitis. And that's different to just some sticky eyes that have occurred because of a blocked tear duct. We need to be able to identify gonococcal eye infection, because some babies can lose their sight if they don't get antibiotic treatment very promptly. And the treatment for gonococcal eye infection, these days, most Neisseria gonorrhea are resistant to penicillin. So we need to give ceftriaxone for those babies. Penicillin or ampicillin and gentamicin, that won't work. We have to give ceftriaxone. And usually a single intramuscular dose of 50 milligrams per kilogram is sufficient. I usually give that and then follow up with some eye drops as well. But these babies need to have ceftriaxone so that their likely resistant gonococcus gets treated. I want to talk just now briefly about torches infections. So this is what we often call them, torch infections. And these are intrauterine infections. They all look a bit the same. And so sometimes it's quite hard to distinguish one type of torch infection from another. There's a few that are different, but some of the torches infections are very similar. And they all can be characterized by the different manifestations, such as microcephaly, or babies that are born with microcephaly, or on ultrasound you see calcification within the brain. Sometimes on skull x-ray you'll see that as well. Often these babies have cataracts, or they may have chorioretinitis. I'll show you some photographs of that shortly. They often have pneumonia from a torch infection, and they often have hepatitis or prolonged jaundice, and they may have a large spleen. And some types of torch infections give you congenital heart disease, particularly congenital rubella infection. Often you get thrombocytopenia, so babies have erythematous rashes, particularly on their skin. And so they're the common clinical features of torch infections, which can be caused by toxoplasmosis, rubella, cytomegalovirus, herpes simplex, and of course syphilis. The other infection that's included in this these days is HIV, of course, but the main ones that present like this with these multi-system abnormalities are toxoplasmosis, rubella, and cytomegalovirus. That's typically the case. This baby had congenital rubella syndrome, and you can see the cataract the baby has, and you can see the baby has a microcephaly. This is the congenital rubella cataract, and so we need to be looking in a baby who presents with microcephaly. We need to be looking for cataracts. We need to be looking for skin rashes, for hepatosplenomegaly, and examining for congenital heart defects that might occur because of congenital rubella syndrome. Cytomegalovirus infection is probably even more common than rubella, and it's probably even more common because it's quite common in the community. Most of us at some stage have been exposed to CMV, but it's typically when a mother develops CMV during pregnancy for the first time. If she's not CMV immune, then it's usually the primary infection that leads to congenital CMV infection. But some mothers can pass on CMV to their babies, even if they've had reactivation or a secondary infection. If a mother has HIV, then her risk for vertical transmission of CMV is also much, much greater. But most congenital cytomegalovirus infection isn't related to HIV. It just occurs typically in a mother who during pregnancy develops CMV for the first time. And in an adult, if we get CMV for the first time, we usually just get a glandular fever-like illness or a flu-like illness with respiratory symptoms, or we might feel unwell, like we've just got the flu, with muscle aches and pains, sometimes with more extreme manifestations like jaundice or night sweats or a rash, but sometimes it's just we feel like we've got the flu. And babies who are born to mothers who develop a flu-like illness in the first in the first particularly 2 trimesters of pregnancy are particularly prone to developing congenital cytomegalovirus. This was a baby who had congenital CMV, and you can see the petechial rash the baby has on the skin. And this is the retinography of a baby who's got cytomegalovirus, where you can see the retinal hemorrhages, what's called chorioretinitis, or significant retinal hemorrhages the baby had. And I think probably congenital CMV is a little bit more common than what we realize, because we don't really test for it. We often don't detect it, I think. But it's actually in most countries, it's the most common form of congenital hearing loss. That's the big problem that occurs from CMV is congenital hearing loss typically. And so if you see a child who's an older child who's got hearing loss, think that perhaps they may have had congenital CMV, particularly if they've got other congenital abnormalities like microcephaly, or they've got as I said, visual impairment. But congenital visual impairment occurs in almost half of all babies who've got a CMV infection. That can be a big problem. Microcephaly also occurs in, as I said, in toxoplasmosis and rubella and CMV, and this can be because of these intrauterine viral infections. Microcephaly, you will know recently, because of the Zika virus outbreaks everywhere, people have been focused on microcephaly, but it also occurs from rubella, from syphilis as well, CMV and toxoplasmosis. All of these different intrauterine virus infections can cause they can cause microcephaly, but there's also other causes of microcephaly, such as genetic or chromosomal causes, and sometimes in different environments, certain teratogens or can cause microcephaly, particularly what's called fetal alcohol syndrome. If a mother has consumed a lot of alcohol during pregnancy, then it's certainly we see it among some populations in Australia, the fetal alcohol syndrome, where babies are born with microcephaly, or if a mother's been abusing drugs, or in some other causes, such as some other drugs causing teratogenic effects. So if you see a baby with microcephaly, first of all, think, could they have congenital rubella syndrome or congenital CMV, or some other torch infection, some intrauterine viral infection, or could it be a genetic or chromosomal problem? Could they have Zika virus, or maybe could they have some other sort of toxin exposure in utero that might cause microcephaly? I want to talk briefly about neonatal tetanus, because that's not so-called one of the torch infections, but it actually is a congenital infection, isn't it? It's an infection that is acquired often very soon after birth. It's not so much congenital as acquired soon after birth, and I think it's important that we understand tetanus and know how to prevent it and treat it. Of course, if you think about what happens at the tetanus is an infection due to the Clostridium tetani toxin, isn't it? So the infection is often on the umbilicus. In these 2 babies, there was an umbilical infection that led to, with Clostridium, that led to the Clostridium tetani, leading to the manifestations, the motor manifestations of tetanus. And so to just be clear about what the Clostridium tetani toxin does, you need to understand what the normal neuromuscular transmission is due to. And we all know that, I'm sure we all know that acetylcholine is the neurotransmitter that is at the neuromuscular junction, and that gets released from the nerve endings and stimulates the acetylcholine receptors on the muscle, and then they contract. So normally acetylcholine goes across the neuromuscular end plate onto the muscle and stimulates the muscle. But there is an inhibitory neurotransmitters that stop this happening constantly. And if you don't have the inhibitory neurotransmitters, which we talked a bit about before in terms of when we talked about epilepsy, GABA and glycine, they're the inhibitory transmitters. And so if you've normally what you have is the nerve axon terminal, and then the nerve axon terminal has a number of other nerves that come in that have inhibitory neurotransmitters. And glycine and GABA are the inhibitory neurotransmitters, and they inhibit the release of acetylcholine. So they allow the system to balance out. So we're not always in a spasm, in a muscle spasm. They stabilize the axon terminal and block the unregulated release of acetylcholine. That's what normally happens. We normally have acetylcholine stimulation and GABA inhibition. GABA is an inhibitory or a down-regulating neurotransmitter. What happens with tetanus is that the tetanus toxin, it blocks the release of GABA. So the nerve endings that normally inhibit, that release GABA, the inhibitory neurotransmitter can't release the GABA into the nerve axon terminal, and so there's just an unregulated release of acetylcholine, and that just leads to uncontrolled muscle spasm and contraction. So that's what's happening at a molecular level in tetanus. And the reason why it's useful to know this is because it takes somewhere between several weeks and several months for the nerve endings to release the tetanus toxin. So normally the tetanus toxin stays on those nerve endings, those GABA inhibitory nerve endings, for even up to several months. And it takes that long for that balance with GABA and glycine, the inhibitory neurotransmitters, to sort of return. So that's why tetanus takes so long to treat. And that's why giving antibiotics just by itself won't actually treat tetanus. It's important to give antibiotics, but we need to support the child in other ways. So as you know, I'm sure the way we treat tetanus is to avoid unnecessary handling and stimulation and noise. Many of these babies need to have oxygen because their chest wall or their lungs are affected by tetanus. If you have unregulated muscle spasms, then often you'll need oxygen because you may have apnea. I usually treat these babies with a combination of benzodiazepines and other anticonvulsants. And so usually some praldehyde, some diazepam, some chlorpromazine. That's usually, if you use a combination, then you don't typically have to use too much that would cause respiratory depression. Sometimes phenobarbital as well. You would treat these patients with benzoyl penicillin because that treats the tetanus for 10 days. It treats the Clostridium tetani, but it doesn't actually get rid of the tetanus toxin. If you've got tetanus immunoglobulin, then you should give that. So tetanus immunoglobulin given intramuscularly, usually give it on day 2 and day 3, give it around the umbilicus typically, and then again, if you've got more, give it on day 2 and day 3. I usually give 2 or 3 doses at least. Most of these babies need nasogastric feeding, and sometimes they have sort of autonomic dysfunction where they have hypertension and tachycardia, or hypotension and bradycardia. They are very stimulatable, and to keep a child's magnesium level high is sometimes helpful in diminishing the muscle spasms. You have to keep doing this for several weeks or even several months. And the first child I showed you with tetanus, this boy here, required all of that treatment for 2 or 3 months, and he eventually came good. And remember, after treatment of tetanus, if you can treat it properly, then a child's brain should be normal, because it doesn't actually affect the brain. It only affects the neuromuscular function. So if you can maintain their nutrition and protect their lungs and stop the muscle spasms for several months, then they'll get those children will get better, and they'll be normal. So it's well worth trying to treat. Of course, it's even more important to prevent tetanus and give tetanus toxoid to mothers in pregnancy, of course. Now, this is another Torch's infection, and I'm sure you know what this is. Can anyone suggest what this is?
Syphilis.
Congenital syphilis.
Yes, this is congenital syphilis. Very good. And in congenital syphilis, you can get a variety of different manifestations, but you can see both of these babies are low birth weight. This is a very premature baby, and the one on the left is a low birth weight baby with intrauterine growth retardation. You can see that this baby's got skin peeling, and this baby also looks like there's necrotic lesions on the feet with some peeling of the skin. So the manifestations of congenital syphilis can be many, but look on the hands and the feet for peeling skin or rashes. You can see some rashes there, but typically rashes on the palms of the hands and the soles of the feet. This baby's got abdominal distension, and that's common in babies with congenital syphilis because of hepatomegaly and also because of splenomegaly. That's common. Babies are also more likely to be preterm or very low birth weight if they've got congenital syphilis, and they may have also syphilitic pneumonia or syphilitic septicemia. They sometimes have coagulopathy, so they may bleed more often. This is a baby also with congenital syphilis, and just shows the different manifestations. This looks like a vesicle, doesn't it? It's just a large vesicle. You can see some other patches on the skin here, and this was a baby also with congenital syphilis, and this is one also with congenital syphilis. You can see the erythematous patches on the skin on the soles of the feet here, and this one on the right hand side also has those necrotic lesions on the soles of the feet. So they go through different stages of erythematous papules or to peeling skin, and the skin peels off, and if they get treatment, then the skin heals normally, typically. Again, this baby's got abdominal distension and due to hepatosplenomegaly. The manifestations of congenital syphilis are several, and you need to know these. So low birth weight, preterm, they're more likely to be preterm or low birth weight, more likely to have anemia. Often when they're born, they have anemia because of the way it affects the bone marrow. They may have hepatosplenomegaly. They sometimes have ascites, and again, those three things can lead to the abdomen being very distended. They often are jaundiced, and they may have pneumonia, and they have periostitis, which is like an osteomyelitis, syphilitic osteomyelitis. This was a study looking at all the babies with syphilis in Goroka, and what was surprising was that perhaps not surprising, but many of the babies had low birth weight, and the lower the birth weight, the much higher the likelihood of death, and such that babies under 2 kilos of weight, birth weight, had about a 60% chance of dying. So because they had many more of these manifestations, but it just shows you that babies who are asymptomatic and normal birth weight, they have a very low risk of dying, but babies who are low birth weight have a very high risk of dying if they've got congenital syphilis. So if the baby is symptomatic and the mother is VDRL positive, then we should treat with if the baby is asymptomatic, just no symptoms, normal birth weight, no clinical features of syphilis, and the mother is just VDRL positive, then we should treat with benzathine penicillin, right? So the doses are there. That's if the baby is asymptomatic. So to be asymptomatic, you have to be a normal birth weight, not preterm, not anemic, have no hepatosplenomegaly, no ascites, no skin lesions, no jaundice, no pneumonia, and no bone lesions. And so we should look for all of those. If a baby's got none of those, then treating with benzathine penicillin is okay if the mother's VDRL positive. But if the baby is symptomatic, if they've got any of those clinical features, if they're preterm or low birth weight, then they should be admitted and treated for 10 days with benzyl penicillin. The two, I'll just explain that the two different types of penicillin are quite different. Benzyl penicillin is a short-acting, this one, benzyl penicillin, crystalline, what we call crystalline penicillin, is a short-acting penicillin. It has a short half-life, but you achieve quite high blood levels, and that will treat and kill bacteria. The benzathine penicillin is a longer-acting penicillin, And you might think that's good, and it is good, but it you only achieve quite low blood levels. So it's useful at preventing an infection in a child, such as who's got rheumatic heart disease. It will prevent that infection. But if you've got a streptococcal infection, for example, you wouldn't use benzathine penicillin alone. You would use benzyl penicillin because you achieve bactericidal levels of the antibiotic. This will give you bacteriostatic levels and low levels that last a long time, like 3 weeks, typically 3 or 4 weeks. But benzyl penicillin is short acting and it achieves very high levels. So that's why we treat symptomatic preterm or low birth weight babies with benzyl penicillin, crystalline penicillin, or otherwise called penicillin G. We should also treat the mother, of course, if baby's got syphilis. Now, I've almost finished the talk, but I wanted to just explain that in the latest version of the Paediatric Hospital Reporting Program, that's version number 12, we've included a more detailed analysis, I suppose, of the different types of neonatal infections. And so instead of just calling it neonatal sepsis, I think it's important that we are a bit more detailed in the way we describe neonatal infections. So whether it's neonatal pneumonia or meningitis or cord sepsis or skin sepsis or congenital syphilis or congenital malaria or congenital rubella syndrome or neonatal tetanus or diarrhea or some other infection, a neonatal infection, or we've even included COVID, acute respiratory infection, in here because sometimes babies are born with COVID infection. So the point of that is so as in the future we'll have more data on the different types of neonatal infections that occur, and then we'll have a better understanding of which ones are very common in PNG and which ones are changing. I wanted to just touch on briefly on prevention. In fact, this is probably the most important part, because many of these infections that we see in newborn babies can actually be prevented, and they can be prevented, of course, by aseptic deliveries, so clean deliveries of mothers, by skilled birth attendants, by a midwife delivering the baby or an obstetrician delivering the baby in a health centre or a hospital where they can get a clean delivery. And so that's primary prevention. Secondary prevention is when a baby's first born, we should do what's called EENC, or early essential newborn care. And that involves maintaining skin-to-skin contact with the mother. So when the baby's first born, then making sure the baby is in contact with the mother. And the reason for that is if you take the baby away and have the baby in a nursery, then they're likely to get some hospital-acquired infection. But if you keep the baby with the mother, then they'll acquire the bacteria that are on the mother's skin, which are generally healthy bacteria. And and they'll also be able to more easily breastfeed. And that's a big way of preventing early infections, because breast milk has, as you know, colostrum has lots of antibodies that protect babies. And so the better we can establish breastfeeding and have skin-to-skin contact, then the more likely we are to prevent early infections in babies. We shouldn't really separate babies from mothers if we can possibly help it. We need to have strict hand washing and other basic infection control measures, and this has become obviously more important with COVID. And we need to have a sort of a program really of antibiotic stewardship where because we should only give babies antibiotics if they really need them, because antibiotics have a big effect on newborn babies. They can change the flora, the pathogens in the baby's gastrointestinal tract. And when a baby's born, of course, their gastrointestinal tract is sterile, but in the first few days or a week of life, they're acquiring all the normal bacteria in their gastrointestinal tract. That's a normal process. It's not disease, it's a normal process. But if we give them antibiotics, then they're likely to be colonized with resistant bacteria like gram-negative bacteria instead of the protective bacteria they need to get from the mother. So lactobacillus and bifidobacteria, and they're the protective bacteria that we have mostly in our gut. But the more we give antibiotics to babies, then the more likely they are to have different bacteria. And this can this can mean long-term consequences for babies. So of course we should give antibiotics to babies that have got genuine newborn sepsis, but we should try to avoid them or give only shorter courses if we find babies have mild infections or they improve very quickly. And so I like to cease antibiotics after 24 or 48 hours. If a baby's well, it's okay to start antibiotics, but we should try to reduce the colonization of babies with pathogenic or highly resistant bacteria, and that will reduce infection in babies. And it also will reduce a lot of other things later on, because we know that babies that are exposed to antibiotics, like prolonged antibiotics in the first few weeks of life, are a bit more prone to getting even asthma, for example. So we by reducing our use of antibiotics and keeping them only for the infections that are serious bacterial infections, then we can save babies a lot of problems, both in the short and the longer term. And I finally want to say, I said at the start that often we think it's hard to distinguish between bacterial infection and some other infections. And we often do a full blood examination, but I don't think we sometimes don't really analyze the full blood examination to see all the signs of bacterial infection. We often just look at the white cell count, like the total white cell count, and see whether it's high or normal. And if it's high, we say it's a bacterial infection. But I want you to look a bit more deeply at the full blood examination, because we get a printout and you can look at all the different parameters to see which ones suggest a bacterial infection. So obviously, if the white cell count is very high or actually very low, then that suggests a bacterial infection. If there's very high or very low neutrophils, that suggests a bacterial infection. Even more specific is if the band count is very high, or the myelocytes or the metamyelocytes. They're the immature forms of bacteria of neutrophils, and they're stimulated by the bone marrow when there's a serious bacterial infection around. So we should look for those immature forms, band forms, myelocytes and metamyelocytes. We should look to see what the platelet count is, because if it's very high, like over 800,000, or it's very low, then that is also a sign of a bacterial infection. And there's this other parameter on the blood film that I often have told you about, I think called the red cell distribution width, the RDW. And again, when you've got a bacterial infection, then often the RDW is actually quite high. So it's often not one thing that we're looking for, but a combination of these things. If all of these are normal, if everything's normal, the white cell count's normal, the neutrophils are normal, there's no bands, no myelocytes or metamyelocytes, the platelet count's normal, the red cell distribution width is normal. If all of those are normal, then it's highly unlikely that there's a systemic bacterial infection, a serious systemic bacterial infection. But if they're abnormal, then it should stimulate us to think that perhaps there is a serious bacterial infection. We can sometimes measure other things like an ESR or a procalcitonin. Some places can measure these things, and they can also be helpful. But what we should make the most of what we've got, and that is a full examination of the full blood count, and see if there's signs of bacterial infection or not. And then we can use that to decide whether we continue antibiotics or we can stop them. All right. That's actually all I had to say today. But I hope that's been useful in running through different types of neonatal infections, because they're so common. We need to be familiar with and experts in all these different types of focal and systemic bacterial infections, and focal and systemic virus infections, and intrauterine viral infections, the torch infections, etc. So I'm going to stop there. If there's any questions, I'm happy to answer any questions that you might have.
Thank you very much, Professor. Just one question. And can you just go through again on the frequency of giving antibiotics? Like in the first week, we give BD, and then the second week, we give TDS, or we straight to QID, for example, for ampicillin?
Yes. Sorry, with The frequency. So in the first few days of life, it's in the standard treatment book, the differences, but typically the half-life of many antibiotics, not all, but many antibiotics is longer in neonates, especially in preterm neonates. And usually we would give them a little bit less frequently in the first week of life. But if you've got a very serious bacterial infection, then giving flucloxacillin QID is okay. If you've got a preterm baby, then sometimes just giving it BD is good enough. It's in the hospital care for children book and in the standard treatment book as to what the frequencies are for different antibiotics at different ages. But the principle is that the half-life is typically a bit longer for aminoglycosides and for penicillin-like drugs, so flucloxacillin and penicillin. And sometimes for preterm babies, we only need to give it every 12 hours. But again, it does depend on the severity of infection. And if you've got a very severe bacteremic infection with Staph aureus, for example, I would still give it every 6 hours in the first week of life.
Thank you very much.
I wondered if Dr. Gamini Valley is on the line, and Dr. Valley is our neonatal expert. Did you have any other suggestions or other points to for teaching? It's okay. If anyone's got any other.
Sorry, Prof. I'm trying to.
Oh.
Can you hear me now? I'm just trying to.
Sorry. Yeah.
Looking for the unmute button. So yeah, I think neonatal infection is one of the important cause of morbidity, and if we are not careful, mortality of our neonates. Very important. Like it, I think it's one of the apart from prematurity, we know asphyxia, neonatal sepsis is one of the common causes of morbidity. Yeah. Very important. Like we've with the different types of neonatal infection that you've gone through. Most of the, like in special care nursery, most of the one of the things that I basically especially in babies that we have to, I try to teach the residents and even the medical student to try to talk to mothers, because some of these babies, because of the increased turnaround, deliveries in Port Moresby General Hospital, sometimes we overlook some of these babies, and when they go home, they come back very sick with probably just bacterial infection or neonatal pneumonia or skin sepsis with, Staph pneumonia and all this. So I try to talk to them about, like, take time to just sit with them to educate them about the dangerous signs. Very important, so they can identify, they are aware of these dangerous signs, and when they go home, they try to, if there is any, then they bring their babies back to the hospital for further treatment and admission. Or but it's a big challenge for us, neonatal infection. Yeah, we're still having a lot of neonates coming back to our wards less than 28 days, coming back to the general ward with basically skin sepsis and just bacterial neonatal like infection. Yeah, so as you know, Port Moresby delivers about 14,000 plus deliveries, and you know, some other things that basically contribute to neonatal infection is the poor socioeconomic status of, you know, people, like water, sanitation, and all this hygiene back at the community. Yeah.
Yeah, thanks, Kamini. That's very important, that we need to teach parents how to care for their baby when they take them home and how to protect them from infections, isn't it? So, you know, as we talked about last week, in, you know, the education of parents who have low birth weight babies is very important, but also, you know, for general parenting education and how to bath a baby, how to, you know, clean a baby properly, and how to provide nourishment, and all those things can help protect against infections. So yeah, very good point. Thank you. All right. Okay, well, if there's no other questions, we might stop there. And so thanks everyone for coming online today. Now, I'm going to be away for 2 weeks now, so that gives you a break for 2 weeks from these talks on Mondays. So we'll start up again in 2 weeks' time, if that's all right. So not next Monday or the Monday after, but the Monday after that. And but I'll send something around about that. But for the next 2 weeks, you can have a break and just do some study yourselves. If you've got any ideas for topics for in the coming weeks or months, then please let me know. There's plenty of other things we need to cover though for the rest of the year. So look, thanks everyone for coming on today. I've tried to record today's